Okay, I think we can get started. We have kind of a quorum of about 15 people this morning, so thanks for making it to this point. This is our last session in this series, and as we talked about over the last couple of weeks, the format for Echo is going to be changing. There will not be an Echo series this fall. We're going to kick off with a new series in 2025 that focuses upon quality improvement and strategies related to it, very much aligned with improving healthcare delivery and for all populations, and not just for diabetes, but in general. So I will be co-leading that with Elise Caron, who is based at Metro Health. So this session, however, is a wrap up, and it's an opportunity to tie up any loose ends, ask any questions that you perhaps didn't get a chance to ask, or even that might have come up over the last couple of weeks. So let me see if I can advance. Again, no PHI, please. Usual information about assistance, about cardio, our team. And Kathleen and Karen, I think, are probably best prepared to answer some of the questions that might come up, but everybody is welcome to participate, of course. So no new disclosures. These are our general objectives. And see if you do have any questions related to social determinants of health and that were not addressed previous to this session. We can address those today. So this is the first question that came up, and I'm willing to offer my perspective, but I would really, of course, like Kathleen and Karen and others to participate. So it's a big headache. So in terms of insurance coverage on medications, is anyone familiar with a program or reference which presents the insurance industry in an understandable and useful manner? Boy, wouldn't that be wonderful? So, and I'm trying to look and see who has experience with, I mean, Austin is in primary care as well. So I don't know if you've got Epic, Austin, but I go into it and then I'll start, let's say, prescribing Rybelsus, and then something pops up and says prior authorization required, go to cover my meds. I go there, answer some questions. I can never get it in properly. The birth date or something doesn't match. If it does, they'll let me know. And a couple of days later, they say no, kind of thing. So anyway, I was looking around. I don't know if there's a better way. That would be a wonderful thing. And am I able to share my screen? Is Rick on? Let's see. Okay. Oh, thank you. Let me see if I can find something for you guys. I don't know where it went. Okay, I did have something that was up here. Whoops, I'm sorry. This is just our general Echo screen. So there is a website, and I hope you guys can see this okay. From Ohio Medicaid, and way down at the bottom here, there is something where you can actually look for, it says my care prior authorization requirements, but that's only for continuous glucose monitors and strips. So I looked at that, but there is something else. Hang on a second. This is the Gainwell site. Gainwell does manage Ohio Medicaid's, it's like an ODM for Medicaid, I believe. So drug coverage information, gosh, you have to really look down here. So this is the supply list, etc. Durable medical equipment, and the coverage OTC list. An online drug lookup tool is what you have to go down to. And it goes to Gainwell. Now let's say I go to this website and I have something that we want to give them semaglutide. And this is all I got. And it talks about Ozempic and prior authorization required, et cetera, et cetera, et cetera, the copay. But it doesn't really tell you what the general prior authorization requirements are, which is unfortunate. So could we go back to the PowerPoint slides?
Dr. Rao, there is a way on the ODM website that you can see the clinical criteria. Were you going to, I don't know if you were going to get to that, so I don't mean to
No,
cut.
I'm hoping you could
Yeah,
enlighten us.
yeah, yeah,
Someone.
I'm happy to.
Yeah.
So there, do you want me to share
Apparently
my screen?
it's yeah, it's set up. You should be able to share your
Okay,
screen.
Okay, thank you.
yeah,
Appreciate it.
let me pull it up real quick. So luckily with Ohio Medicaid, just in general, I mean, just from working with other like clinicians across the country, I think our Medicaid is set up really nicely that they give us exactly what's covered. We have one single PBM, and we don't have to like sift through what may or may not be covered. So going to the same screen, can you see this? Is it
Yes.
blinking? Okay.
Oh,
So I just Googled
mhm.
ODM. I don't remember what I Googled, like Ohio Medicaid pharmacy. And it takes you to this initial screen. Sorry, our internet is being odd. Um, sorry, I just had it loaded. I don't know what's happening now. Okay, so it takes you to this initial screen. And if you click on, there's two things that you would want to look for. This unified preferred drug list, which is
Mhm.
literally a PDF of all medications that are covered, or this drug information coverage website, which is exactly what you just had up. So here is the unified drug list. This is updated every quarter with Medicaid. So most recently it was updated April 1st. But then the thing you want to look at for clinical criteria is right here. So if you pull this up, it will actually go through class by class what the PA requirements are. So a lot of times I utilize this for like PCSK9 inhibitors. What else? GLP-1s, and it'll kind of go through exactly what the requirements are. There is another sheet that looks a little bit different than this. I can't find it off the top of my head. If I find it, I can send it out to the group, but it will go through again, like more information on what exactly the clinical criteria is. So like, for example, like semaglutide is not preferred. They prefer
Right.
dulaglutide and
Mhm.
liraglutide first. And so they kind of go through this, but it is updated every quarter, which is super nice.
That's helpful. Thank you, Mary. And Kathleen just
And
put
then,
it.
yeah, Medicaid is really nice. I don't know if anyone has any tricks for Medicare, and commercial insurance. Those are the ones that we always, I mean, it's so widely varies. Even just searching for the plans, you might have insurance card in front of you and you're trying to find the plan formulary online. It's so hard. You had mentioned with Epic, that is helpful to an extent, but in Epic, at least at our institution, the insurance that gets added into a patient's chart is their medical benefit. So, for example, like UT employees here, we have Medical Mutual as our medical benefit, but then we
Mhm.
have a very small PBM called Surpass. So, if I put in a prescription and it's under Medical Mutual, like it will run it under Medical Mutual, like generic coverage, but it might not be specific to the Surpass, like pharmacy benefit manager. So sometimes I would say like 50 to 70% of the time that's probably accurate, but then we run into issues where it's like, I know this is covered because this person's an employee, but it's telling me it's not. So that's
Yeah,
just
I
a
haven't
dilemma.
found the Epic alert to be terribly helpful. So my shotgun approach to it is to prescribe, wait for somebody to request a prior authorization,
Yeah.
and then go into it. So Kathleen just mentioned that we do have a cardio sheet as well. Kathleen, is that right? That will help us.
Yeah, and we checked it a few months ago, so it's up to date now. So yeah, I agree with Mary Lee. The Medicaid is relatively straightforward, but all the other payers are, incredibly challenging.
Right. Okay. Any other insights? Karen, any insights from you on maybe durable equipment or other supplies or that you might have experience with? You're muted, Karen.
Of course I am. Do that every time. For medical, for well, equipment here at our institution, we go through Parachute. And that's some kind of an organization that that kind of takes care of the, coverage options. So that's about as complicated as I can get, because I don't order things, I don't prescribe things. But if a person comes into me and they've decided they want a particular insulin pump or sensor, I send the message to the doctor and the medical assistant, and they're usually a lot of times using Parachute to expedite things.
Okay.
The
All right.
Parachute is really nice on the provider end, because once your nurse or your whomever fills, if you have support staff, they can complete all of the fields, and then they literally just send you an email and you click approve, and that's all I have to do. So Parachute's really nice, and they have subscription forms that you can actually do even more sophisticated integration within Epic. For the devices, the one piece that I would really emphasize is if a patient is told that their CGM is not covered, never take that as a final answer, because often it is covered, or it's a little bit cheaper if they go through a DME company, especially Medicare. I can't tell you how many times people have come to me and says, well, I have Medicare and it's not covered. I'm like, well, yes, it is covered. So they just don't know, and pharmacies don't tell them.
That's helpful.
One thing that's been helpful for us for prescribing DME, we also use the Parachute. So it just essentially allows for electronic prescribing of DME, where you don't have to like have the wet signature and all of that. But we have 2 DME companies that have like basically reps that are here in Toledo. Like the company itself is not physically located here, but we've made like good relationships with those affiliates, and they oftentimes are people that we reach out to. Like, this person has this insurance, I've sent it to the pharmacy, I'm trying to put it through Parachute, it's not working, like, what do I do? And a lot, those people are really knowledgeable about like the ins and outs of coverage for the DMEs and like CGMs, pumps, stuff like that.
Great. Thank you. All right. Can we go back to the PowerPoint slides, please, Andy? Okay, so I think that's extremely valuable information, and thanks, Marilee, for pointing me in the direction of the Medicaid clinical criteria. The second question we have is, how does the history and current state of the insurance industry affect the coverage of medications for our patients? I suppose this question is asking about what the prospects are in the future. I don't have a lot of insights. I know that some of the first GLP-1s, Byetta, for example, exenatide, is going to go off patent, I think, late this year, but that doesn't mean the price will come down. It's not widely prescribed anymore anyway, but it will be a couple of years before it does, and it should come down significantly. But if anyone has any insights about this, I'd appreciate it, because I don't.
On the flip side of things, because of the widespread interest and demand for GLP-1 based therapies, many insurance companies are actually really severely limiting or stopping coverage when it's used for weight loss. Not so much for diabetes. I don't think that's going to change, but there are more and more health plans that are just deciding not to cover it at all for weight loss.
Yeah. So there's a rep who comes to our FitterMe clinic periodically from Novo Nordisk, and which makes Wegovy and Ozempic, and I think is now one of the most valuable companies in the world. It's from Denmark, and its company's worth as much as the whole country of Denmark, basically. So he had some really interesting insights. So the price of that drug, which is still profitable in Germany, is about $330 a month, about 1/4 of what we would pay here. And in Britain, it's about the same amount. And he says that might be a direction that the company would look at in the future, is just bringing down the price. And we'll see how that goes. Paul, sorry, you had a comment.
No, thank you. I'm by no means an expert. I had an opportunity to work for a pharmacy benefits management company for a while, and you guys may be familiar with what goes on the other end of the phone. If you or somebody in your office is dealing with an individual who's trying to help you with prior authorization, the individual sitting on the other end of the line, and maybe a pharmacist, sometimes it's not, I think often it is a pharmacist, he or she is literally reading off of a script, and that script is based on medical evidence. A, has this been tried? B, has this been tried? C, has the client or the patient failed on this medication or this therapy, that kind of thing. And those scripts change in time. Somebody mentioned might have been merely update on a actually 3-month basis. I'm actually a little bit more familiar with the Medicaid system in Illinois, where the formulary gets updated on a monthly basis. And are they looking for the least expensive medication? Absolutely. But in order to continue to be in business, they're obligated to offer at least 2 medications if they're available in each class, as long as the medication has the indication to treat a particular disease process. I know I'm being a little bit wordy here, but there's also a phenomenon known as the participation fee. These products are ethical, they are safe, they are effective, but in order for a company to get their product listed on a Medicaid formulary, they're obligated to offer a participation fee, which is basically just with respect. Another word for a bribe. The company pays money to the state, whether it's Illinois or Ohio, whatever it might be, to get the medication listed on the formulary. The medication has to be safe and effective and has to be indicated. There's no doubt about that. But if the company's not willing to pay the participation fee, then they may not find their product listed on the formulary. Oh, wow. It's an extremely complex system. And all of the feedback here has been obviously very, very helpful, particularly for you guys who are involved day to day for being the direct providers. I think all of us could benefit in, I don't know, maybe someday I'll sit down and write it, a history of the insurance industry. Why are we dealing with what we're dealing with? If I may, let me pontificate for just a moment. Is the way we're paying for health insurance, is it actually insurance, or paying for health care, is it actually insurance? I don't think so. Automobile insurance pays for catastrophic loss. Homeowners insurance pays for catastrophic loss, not everything. When we're dealing with health, quote unquote, insurance, it doesn't pay for catastrophic loss. It's expected to pay for everything. And that's not necessarily an unhealthy expectation, but it's an expectation that we have arrived at as a result of what has happened in our country in the last 50 or 60 years with the social programs and the government programs and everything. So we may be doing ourselves a benefit or a favor if we find a way to describe it other than insurance, because health insurance doesn't pay for catastrophic loss. It's expected to pay for everything. And I think that helps explain the level of frustration on the part of patients, certainly on the part of providers, and certainly on the part of companies who are manufacturing goods or providing services, because they're expected to pay participation fees to be involved in the system. And again, I know I'm being very, very windy here, but just I think one of the takeaway points here is when somebody in the office is communicating with somebody talking about a prior authorization, the person on the other end of the phone is literally reading off of a script, and that script is based on current medical evidence and the medications that are accepted on the formulary based on the criteria that I just talked about.
Thank you, Paul. I would just add that's a very tedious process to get on the phone with one of these people. We prescribe these medications at the Fit or Me clinic, for example. I spend about 20 minutes with each patient, and then the phone call for prior authorization can last longer than that. So just to get the medication done, it's just hope there's a better way in the future. Any additional comments about either of these questions? Okay, if not, I think we can probably move on to our case.
Well, cool. Actually, I think those are great questions, because I've been on a couple different echoes now, and I still struggle. In fact, I had, if you remember years ago, and they might still have it, Walgreens just had to check your glucometer, check batteries, check sensors. And there was just a physical form you'd sign and send off. And then whether it was Freestyle or whether it was whatever brand was on, you didn't have to change it. And I debated for a while because I don't have Epic, and I didn't have the ability to check to see what the cost was, or the sense, how, if it's covered, and start doing the cover my meds and all those things. I said, I'm just going to, develop a prescription pad that lists like every starting dose of a medicine, and just be like, if not this, move on to this, then move on to this, because I don't want to do it. Like, pick the one that works and let us know. But
Yeah.
These echoes have been so helpful because I'm just down here in rural America playing around, and I don't have a pharmacist, I don't have a dietitian, I don't have a diabetes educator, and I really don't even have partners or drug reps or anybody else helping out. So it has been a huge benefit for my practice, my patients, to be able to run all these by you guys for this long. So thank you, thank you, thank you.
All right. Thanks, Austin. All right. Back to you, Andy, for a moment.
Okay, so just as a reminder that we will be shifting our Echo series. So look out for information about that soon, probably in the fall. Our May webinar is coming up soon. You can register on the Cardio website or through the QR code. All past and present Echo clinics are available to you on our website. And then just some end of the series reminders. You'll be receiving a post-clinic survey soon. Please complete that by tomorrow night at 5. You will also be receiving an exit survey for the series as a whole. We would really appreciate your feedback so we can grow and improve. So please complete that by May 10th. And then also watch out for a CME survey from myevaluations.org so you can receive credit for this series. And those will be due by May 17th. And just let me know if you have any questions at all.
Okay, thank you, everyone. Another great series. Please do enjoy the rest of spring and your summer, and I hope to see at least some of you. Well, I mean, we'll see our content experts, of course, but in the new series, we're going to start planning that as soon as possible. So have a wonderful next few months. Take care. Have a great day as well. Bye-bye.